sorry, GABA attachment, whether it be benzos or phenobarb, right? Those are what are going to fix the underlying alcohol withdrawal symptoms. But as far as the other SNS symptoms, other symptoms of agitation and such, that's where we could give dexmedetomidine, ketamine, Haldol, etc., right? And those guys will work for NARD, right? Those are going to work as well. Okay, so that's the idea behind delirium tremens, which happens usually about 3 to 4 days afterwards. Again, it's progressive, where they start getting a little agitated, they get more agitated, they start getting more prominent SNS hypertension and such, where they are developing over 3 to 4 days, where they have these profound alcohol withdrawal symptoms. They may even have some of the seizure activity preceding delirium tremens. For about day 1 to 2 is where they get the seizure withdrawals. Okay, so that's the idea behind alcohol withdrawal, is that we are, looking for where we've removed alcohol, the depressive or the inhibitory substance in our brain. All right, so cirrhosis. So cirrhosis, again, we are breaking down the normal function of the liver. The liver has more than 500 functions, so we're going to have like 1,000 symptoms. But as far as the complications, there's going to be a lot of complications as well, right, which are on top of the symptoms. So we've talked about variceal bleeds over in the GI section, right? And we know that cirrhosis, we've kind of mentioned some of the causes of our cirrhosis being they have a, Hep B, Hep C due to scarring, right? It goes from a natural liver to a cirrhotic scarred liver that's kind of tinier in size, right? You can see that an echo, they can do what's called a fibroscan, and they can bounce little sound waves off of it, and the more fibrosed it is, it's going to lead to more. They can tell how bad their cirrhosis is based on that scan, right? And as we have that more cirrhotic presentation, that's going to make it difficult to get blood through the liver itself, right? And that's going to lead to what? Increased what? Portal hypertension, right? And that's how we get into the variceal bleeds, right? So we get poor blood flow through the liver. What else can cause cirrhosis? Well, it can be due to congestion, right, from the heart. The heart backs up in the liver itself, like right heart failure or really bad left heart failure that makes the right side fail, and that can then back up the liver, causing liver congestion, and that's called cardiac cirrhosis, right? So cardiac cirrhosis is a problem due to CHF, just adrenal shock states, right? So we've got a really bad shock, right? Low blood pressure to the liver, low blood pressure to the kidneys, cause your kidneys to fail, low blood pressure to the heart, cause your heart to fail, low blood pressure to the brain, cause your brain to fail. So it's the same thing. You can get shock liver because of a cardiac arrest, for instance. Okay, there's genetic reasons that you can get liver failure. There's buildup of iron. You can get buildup of iron when you have too many transfusions in your lifetime. I think it's like over 30 units usually puts you at highest risk of iron. There's also genetic reasons why you can't store iron appropriately. All right, so hemochromatosis, you can't store copper appropriately. You get it's called Wilson's disease. There's alpha-1 antitrypsin disease, which you learned about with COPD, right, back in the day, and then that also damages your liver too. Okay, so biliary disease, there's random biliary diseases. Would like a cholecystitis cause it? Not really. This is usually more of a genetic situation or inflammation of the biliary tree chronically that would cause a scarring and cause a damaged liver. We talked about NASH briefly, right? Non-alcoholic steatohepatitis compared to alcohol. Alcohol causes steatohepatitis, but NASH is not because of alcohol, right? It's because of diet intake that caused them to become cirrhotic over time. Okay, and of course, alcohol causes direct fattiness of the liver as well, because it's excessive carbs that get deposited somewhere and deposits on the liver itself. Okay, we talked about Hep B briefly, and you can develop. Cirrhosis takes a while to develop. It's usually common in your late 40s, 50s is usually when it starts taking hold. We talked about acute liver failures. Okay, and if you have repeat damage, acute, repeat Tylenol ingestions, that could lead to a cirrhotic presentation, but more commonly it's the E2H with overdoses and E2H hepatitis that will progress someone to E2H cirrhosis. Okay, so those are all the causes and kind of how we got here, right? Cause infections, hepatitis, there's autoimmune reasons, there's E2H, right? Non-alcoholic fatty liver disease, genetic reasons that are all causing us to become cirrhotic, right? Or our liver becomes cirrhosed, or scarred, and therefore leads us to development of portal hypertension. And that's one of our significant side effects or significant complications of cirrhosis are the high pressure within the portal circulation, and truly it's the difference between the two. So the pressure over here is so much higher than pressure on the venous side, the systemic side. That difference in pressure, that difference in gradient is what causes more and more symptoms. Okay, and we talked about variceal bleed over in GI, and all this blood will back up into the spleen, causes splenomegaly, and the spleen gets like a hoarder. It starts hoarding platelets, and you get thrombocytopenic, and then also the liver makes thrombopoietin to make platelets in the first place. So that's going to deteriorate over time, put you at risk for bleeding disorders. And then hyponatremia we'll talk about, right? And that's because all this portal hypertension, you're going to start releasing, it's going to start harvesting or start holding on to a lot of blood volume, right? And your body's like, what the heck? Where's all my blood volume at? And it's like, we need to get more blood volume. How do you get more blood volume in the body? You got to go to the kidneys and tell them, and you have to bring what with you to the kidneys? RAS system, right? Which is where, and that's aldosterone with sodium and water will get absorbed, and also vasopressin or ADH. You're going to absorb water. So you absorb water with ADH, you absorb sodium and water with aldosterone. So that's 2 waters and 1 sodium, right? So what wins? Hyponatremia wins, right? So that's a low sodium. And actually, the level of low sodium correlates to how serious their cirrhosis is. Right? Hepatorenal syndrome, for the same reason, all that fluid is going to the gut, and also your gut starts releasing these little vasodilators that are going to cause, widespread vasodilation through the body, and that can lead to hepatorenal syndrome, where the kidneys don't get the flow they need. And the kidneys will try to release, try to get the RAS going, try to get ADH going, but ultimately we got to try to support it best we can, and they could then progress to dialysis if we don't turn around their hepatorenal syndrome. And the hepatopulmonary syndromes we'll touch on. All right, for some of the same reasons with vasodilators, but sometimes with vasopressors as well, that is to get released. And we'll talk about ascites. Ascites can happen because of portal hypertension, but ascites can be its own thing, where your liver's not making what causes ascites? Albumin, right? So your liver's not synthesizing albumin, and therefore we get a ascites that will develop, right? So we're not synthesizing albumin, low albumin states, and that causes a poor oncotic pressure. So albumin usually holds on to water inside the bloodstream, and if you don't have albumin, all the water is going to leave the bloodstream, right? And it's going to leave in dependent areas, yeah, but it will definitely leave in the acidic area, because that area is under the highest pressure with the most volume. So that's going to be the area where there's the most edema, right? So you get anasarca, ascites, and because of that problem there, you get spontaneous bacterial peritonitis, where it's a ripe area for bacteria to take hold. And we'll talk more about peritonitis and such. Hepatic encephalopathy develops when we have an inability to handle ammonia. We produce too much ammonia. We can't break down. We start breaking down proteins into BUN, but that process gets cut in half, and we start building up ammonia, right? And then when you have a surge response, the ammonia will then leak across the blood-brain barrier and cause a hepatic encephalopathy, right? Coagulopathies we talked about, thrombocytopenia, we talked about the reason for that, and then liver cirrhosis leads to hepatocellular carcinoma, right? And then if you didn't get liver cancer, you lead to what's called decompensated cirrhosis, where you keep having acute on chronic liver events, just like with CHF, you keep having CHF exacerbations, just like with COPD, you keep having COPD exacerbations until you are end stage, and there is no real fix for it, right? We try to give them liver transplant lists. They have to be like under age 65, and they have to meet all the criteria for them to progress to actually get a liver transplant, or orthotopic liver transplant, OLP. Okay, so that's the idea behind cirrhosis, right? We have all these disease processes we talked about that can lead to cirrhosis, and now we have ascites, SBP, varices, we mentioned before, HE, hepatic encephalopathy, hepatorenal syndrome, right? Hepatopulmonary syndrome, and HCC, or hepatocellular carcinoma, that can develop because of cirrhosis. Okay, so like I mentioned, cirrhosis is a damage of the liver. The liver has 500 functions, so we're going to get about 1,000 symptoms because of it, right? And one of the symptoms is we are not getting rid of bile efficiently, and it's actually conjugated, not unconjugated, but this bile starts building up and building up, and we start getting, icteric, which is, yellow sclera. We get icteric skin as well, and you can get pale clay stools, usually when you have biliary involvement as well, but you will have dark urine that will be present, and so that's just the bile story, right? So bile we kind of mentioned in gallbladders diseases, and why that went up, right? We have a yellow highlighter like appearance to our patient, but this will be usually chronic, and the T-bili is the measurement of how much bile is in our bloodstream. Usually when we are greater than 2.5, that's where you're going to start getting the yellow appearance, right? Where you have the buildup of this bile, and it starts, that's going to be their permanent fixture, right? And usually it's also a marker of how severe the disease is. If their T-bili is like 12, it's like not because they have a gallbladder issue, right? It's because that's their liver cirrhosis that's leading to this chronically high T-bili. You'll see really chronic cirrhotic patients, they'll have T-bilis of 18 at baseline, or 12 at baseline, or 8 at baseline. Okay, we do have to look at their history and look to see, was their T-bili 6 months ago? Was it also 12, or was it like 0.6? Because it's 0.6, 6 months ago, and now it's 12. Yet, can cirrhotic patients have gallbladder issues? They just sure can. So we have to look at the trends over time. All right, so other symptoms that might develop, we talked about ascites will develop because we're not making albumin, right? We're not making albumin, so therefore you can't hold on to water in your bloodstream. And where's all the blood in the bloodstream going? It's going to the area where there's portal hypertension, right? We're delivering blood from the heart through the spleen, through the GI tract, and through all the mesentery, and then it's going to land in the portal circulation. And then it's its job to then make its way through a cirrhotic liver. That's not going to happen very easily. So a lot of blood starts pooling in the abdomen and in the portal circulation, and then since your albumin is low, that water is just going to leave the bloodstream and go into the belly, right? So we get ascites as a classic symptom of someone with liver cirrhosis. Okay, and they can move around. This is called shifting dullness, where they move on their side and all the water goes to one side. You can use ultrasound, or they can use percussion to assess that the tympany or the dullness has moved, right? So other symptoms, you got portal hypertension. If you have all that fluid backing up, you get what's called caput medusae. That's where you get this buildup of blood vessels that are prominent in the skin of the abdomen. Even their belly button will reappear, and their umbilical vessels reappear from when they were born, and that's because of the portal pressure that's building up so much, right? So we have this caput medusae that may occur. Okay, it's a caput medusae, and then what else may happen? We have estrogen is broken down by the liver. So if you don't break down estrogen builds up, and therefore testosterone goes down too. So these guys get sporadic chest hair, sporadic groin hair. They get testicular atrophy, and they get this palmar erythema that develops right on their hands because of this buildup in estrogen that will occur because we're not breaking it down. And other symptoms, there's a lot of hand symptoms that happen. There's nail symptoms that may occur. So if you look at your nails right now, you should not have redness underneath underneath the little white tips, right? And you should have that's a sign of liver disease if there's redness right there, right? There's also, your hand should not be contracted. There's the Terry's nails I was talking about. And you should have a good amount of what's it called, lanulae available there. If you don't, that's a sign of liver disease as well. And they have this contracture that develops. It's called Dupuytren's contracture. That happens because they have it's really unknown how it happens. They say it might be magic why that happens, but it's usually found with E2H patients to get this contracture of their hand. And we talked about ammonia briefly, right? So ammonia will not get broken, will be building up and building up and building up, and it can then be exhaled. And it's called fetor hepaticus, which sounds like feces. So they have, poop breath all the time, which is not a great a great breath to be able to manage. So they have this build of ammonia that will be expressed as fetor hepaticus, and also the ammonia can lead to, as it builds up, can lead to a progressive hepatic encephalopathy, as we mentioned, and then it can also disturb nerve endings, right? So we can do we have a symptoms of asterixis. So not asterisks like when you look at the the 8 on your keyboard, right? It has a little asterisk there. It's asterixis, right? So that's where they have this flapping tremor because of the buildup of ammonia irritating the nerves. Okay, so asterixis is a sign of liver disease, but also can be a sign of CO2 buildup. It can be a sign of BUN buildup. It can be a sign, yes, of course, liver failure, but there are other reasons why you have asterixis. It's not like always, oh, you have liver disease, right? So how do they elicit that? So this is an example of eliciting asterixis. So they push their hand back and they should have a little flapping motion. Right, so that's asterixis. All right, it could be high ammonia, it could be a high CO2, it could be a baseline, but usually the examiner is going to hold the hand back and they'll be able to see that that flapping tremor develop. All right, so spider angiomas happen as well. It's usually a sign. The amount of spider angiomas is in relation to the amount of varices they might be developing. So there's a little spider angioma. Compress it and it fills back up. Okay, that is correlates. It's not just a cool thing someone has. It correlates to to cirrhotic patients. All right, so what else? What other symptoms do you want to know about? So there are a lot of symptoms that happen in cirrhotic. So this is an overview of all the symptoms. You can be cool in Jeopardy and say, oh, if they have, if they have Wilson's disease or the copper storage deficit that's genetic, they could have Kaiser-Fleischer rings, right? But yeah, that's not very common. What's very common is the Sharpie-like appearance, or like highlighter-like appearance, the ascites, right? And they can present with complications, right? The hepatic encephalopathy, it could present with varices, and that's where we're going next, all the complications of cirrhosis.